So far, I've explained a lot about perfusion, which is the flow of blood through arteries and veins. And now we're going to talk about the concept of clotting. We're going to look at the exemplars of deep vein thrombosis and hemophilia. Our objectives are to explain the concept of clotting, analyze conditions which place a patient at risk for clotting imbalances, identify when the clotting imbalances are occurring, and apply the nursing process for individuals experiencing problems with clotting, and then explain the correlation between the exemplars and the concept of clotting. The concept map shows our definition, antecedents, which are our processes that we as nurses want to strengthen, the attributes or goals, and positive consequences, which is what we want our patients to look like, as well as the negative consequences, which we don't want them to look like. It also shows us the interrelated concepts that will be affected by impaired clotting. These are gas exchange, mobility, comfort, perfusion, and intracranial regulation. And then you're going to see the importance of the relationship that clotting has on each of these as we go through this lesson. Some of the key points to remember are that clotting is a physiological protective mechanism that allows the body to maintain homeostasis with injury. Excessive clotting impairs perfusion, and inadequate clotting increases blood loss. We can teach our patients to promote healthy behaviors to facilitate normal clotting and prevent negative consequences. And we also want to educate our patients on safety, medications, diagnostic follow-up, and nutritional status that can impact homeostasis. Lastly, hemophilia is a genetic deficiency of factor 8 or factor 9. Females are the carriers, but it is manifested in males. Homeostasis is the tendency of the body to seek and maintain a condition of balance or equilibrium within its internal environment, even when faced with external changes. And it does this by managing a multitude of highly complex interactions to maintain balance or return systems to functioning within normal ranges. The coagulation cascade is one of these highly complex interactions within the body. So what must be in place for the body to maintain homeostasis in clotting and perfusion? These are the antecedents on your concept map and also areas for nursing to strengthen. Tissue or vessel integrity, having or promoting functional bone marrow and liver function, and having normal levels of PT, PTT, INR, fibrinogen, platelet count levels, and the absence of a positive D-dimer in the absence of trauma or injury. The concept definition of clotting is that it is a physiological process in which blood is converted from a liquid to a semi-solid gel. In theory, once the clotting cascade is initiated, it would continue till all blood in the body would coagulate and halt perfusion. But what happens is that anti-clotting forces are also started to limit clot formation only to the damaged areas so that normal perfusion is maintained elsewhere. When blood clotting and anti-clotting actions are balanced, the homeostatic balance of clotting and perfusion is maintained. Hemostasis is the term that refers to the prevention of blood loss by formation of a blood clot. When a blood vessel is damaged, hemostasis takes place through several mechanisms. First is vascular spasm, then formation of a platelet plug. Next is the formation of a blood clot as a result of blood coagulation. And finally, growth of fibrous tissue into the blood clot to close a hole in the vessel permanently. Platelets normally circulate as thrombocytes. that do not clump together until they're activated. The formation of a platelet plug is not a clot, and it may last for only a few hours. The activation factors for the platelet plug initiate the clotting cascade, which will ultimately end with the formation of a strong fibrin blood clot. Thrombocytopenia is a condition of low platelets, and thrombocytosis is the condition of having too many platelets. If even these are out of balance, both extremes will cause impaired clotting. Also, do look at the different YouTubes that I have scattered throughout this PowerPoint because they'll all help you to understand the different aspects of this concept. The primary response of hemostasis involves the formation of a platelet plug, and the secondary response involves a cascade of reactions, the aim of which is to form fibrin. The initial part of this process can be achieved by either the intrinsic or extrinsic pathway. The extrinsic, also called the tissue factor pathway, is the primary means for beginning the clotting process. It is faster than the intrinsic, also called the contact activation pathway. Whichever the pathway, the end or common pathway is that prothrombin activator and calcium ions convert prothrombin into thrombin, which acts on fibrinogen to form fibrin, which strengthens the blood clot. And if any of these factors are missing, the end result will be weakened. Again, look at all the YouTube videos that I've posted, as they will help you to more fully understand this process. This picture is in your textbook on page 789. It shows the clotting cascade as well as where many of the medications that are prescribed hinder the clotting process and lead to a therapeutically longer bleeding time. A static balance of clotting is required to maintain life, and the coagulation cascade maintains that intricate balance. Hypercoagulation can be a dangerous state, especially when these conditions are not properly identified and treated. People with conditions such as polycythemia vera, where the bone marrow produces too many RBCs, are at an increased risk for blood clots because the blood is so much thicker. Clots can develop in the arteries, such as we saw in coronary artery disease, or in the veins, as with a DVT or deep vein thrombosis. A clot inside a blood vessel is called a thrombus when it is lodged, and an embolus if it becomes dislodged and it begins to flow through the vasculature. Coagulation deficits occur when there is a deviation from or an interruption of the normal coagulation properties of the blood. And an inherited deficiency of coagulation factor VIII is characterized by the tendency of spontaneous or exaggerated post-traumatic hemorrhage. Inherited as an X-linked recessive disease, hemophilia A is the most common type of hemophilia, occurring in about 1 in every 10,000 male births. Factors for impaired clotting are twofold. There are factors that can cause clotting to occur too easily, and factors where clotting doesn't occur when it is needed. Some of the factors causing inappropriate clotting include advancing age, which leads to increased platelet adhesiveness, immobility, which slows the return of venous flow, which can lead to a thrombi formation. This is particularly true with certain conditions such as paralysis, impaired cognitive state, or recovery from an illness or surgery. Being confined to a sitting position over long periods, such as when flying internationally, or even professions like a truck driver, have increased risks of abnormal clotting due to decreased mobility. Smoking causes hypercoagulation, and nicotine also leads to vasoconstriction of the vessel. Hypercholesterolemia is a condition that thickens the plasma due to increased cholesterol. And genetic disorders such as hemophilia or other disorders such as polycythemia vera impact the balance of homeostasis in clotting as well. A health history is an important part of an RN's responsibility. With every new admit in the hospital, a complete health history is assessed and documented by the RN, looking at the name, date of birth, age, chief complaint, questions about allergies to the environment, food, or medications, health problems and how long they have been going on, what symptoms are being experienced, any special diet or diet restrictions, list of home meds, family history, career or occupation, normal activity level prior to having the problems, and then there's many, many more questions. Specific questions to ask concerning impaired clotting would be about medications, specifically all anticoagulants, and assessing patient knowledge and usage of the anticoagulants, asking if the patient has bleeding while brushing the teeth or flossing, or if they bruise easily, have any other bleeding tendencies, such as blood in the stool, or asking the color of the stool. These are all very important questions. Also assessing for signs and symptoms of anemia, which could indicate internal bleeding. A basic physical assessment always includes inspection of all extremities for color, size comparison, bruising, petechiae, and any other abnormality in the skin. Palpation of pulses, including the carotid, radial, posterior tibial, and dorsalis pedis, and if indicated, the femoral and popliteal. Assessing skin temperature, especially of extremities, is very important. The PT, or prothrombin time, measures the adequacy of the extrinsic system and the common pathways in the clotting mechanism of all of the factors that are vitamin K dependent. When clotting factors are decreased, the PT is prolonged, which means that it takes more time for the blood to clot. The PT is reported in seconds along with a control value. The patient's value should equal the control value, and the normal is usually about 11 to 12.5 seconds. The PT is used to monitor therapeutic ranges of anticoagulants such as warfarin, which is also called Coumadin, and therapeutic values are usually 1.5 to 2.5 times the normal. The INR, or International Normalized Ratio, was established by the World Health Organization to measure clotting using a standardized sensitivity index. So the INR basically also measures what the PT does and the effect of warfarin, but as a standardized value. The therapeutic value to maintain a slower clotting time and prolonged bleeding time for an INR is 2 to 3.5. Whereas for a normal healthy person, an INR would be about 1. Another lab that is important is the PTT, or the partial thromboplastin time. This measures the intrinsic system and the common pathway of clot formation. When clotting factors are reduced, the PTT is prolonged, and like the PT values, PTT results are reported in seconds with a control value. Normal values should be approximately equal to the control value, and the normal PTT is 60 to 70 seconds till clotting occurs. To shorten that time, activators have been added to the PTT reagents, and this shortened time is called activated PTT, or APTT, with the normal value of 30 to 40 seconds. And this is the one that is more commonly used in the hospital, the APTT. Both of these are used to monitor the therapeutic ranges of patients taking the anticoagulant heparin, and the therapeutic values are again about 1.5 to 2.5 times normal. The last one we'll talk about is fibrinogen, which is in the common pathway to convert or be converted to fibrin by the action of thrombin during the coagulation process. Reduced fibrinogen levels occur with patients with liver disease, malnutrition states, and coagulopathies such as DIC, which is disseminated intravascular coagulation. Normal adult values range from 200 to 400 milligrams per deciliter, and for newborns, fibrinogen levels are 125 to 300 milligrams per deciliter. Coumadin and heparin affect factors on both sides of the coagulation pathway, the intrinsic and the extrinsic. So giving either Coumadin or heparin will cause prolongation of both the PT-INR and the PTT. However, in general, the PT-INR is a better test for monitoring patients on Coumadin, and the APTT is a better test for monitoring patients on heparin. Coumadin works by inhibiting the vitamin K dependent coagulation factors so that they are unable to bind to calcium, which renders them ineffective. That is why vitamin K is the antidote for a prolonged bleeding time caused by Coumadin or warfarin. Heparin works in a totally different fashion. It binds to antithrombin 3, which acts on a number of different factors on both sides of the cascade, but heparin has more of an effect on the intrinsic arm than it does on the extrinsic arm of the coagulation. And protamine sulfate is the antidote of heparin. Some other important diagnostic lab tests include the platelet count, or the number of platelets, also called thrombocytes, per cubic millimeter of blood. Normal adult and children values are about 150,000 to 400,000. Preemies are a little lower at 100,000 to 300,000, and full-term infants are even higher at 200,000 to 475,000 before it begins to decrease. I couldn't find it documented, but I've read previously that the platelet count is at its highest on the 8th day, coincidentally when Jewish people were told to circumcise their babies a long time ago. That's just an interesting aside, I thought. Other diagnostic tests are the red blood count and the hemoglobin and hematocrit. These are used to diagnose conditions with very high levels, which can lead to an increased clotting, or very low levels, which can indicate that internal bleeding could be occurring. Bone marrow tests will show if there is a hyper or hypoproduction of any of the blood cells, such as the platelets in the RBCs. The PT, INR, and PTT labs measure prolonged bleeding time when we therapeutically want to hinder clotting. There are other labs that are used to identify prolonged clotting. These labs are used to rule in or out the formation of a thrombus or large blood clot, and they are the fibrin degradation products, FDPs, and the D-dimer products. Thrombin forms blood clots, and plasmin breaks them down. So the fibrin degradation and D-dimer products are produced when plasmin breaks down the fibrin clot. The FDP lab measures the amount of fibrinogen degradation, and it provides a highly sensitive but non-specific measurement of clots being dissolved. Remember that clots are always forming and always being broken down at the same time, so even small normal clots give off enough FDPs to make the FDP test register as positive. D-dimers are more specific for actual clots than the FDPs are, because you only get a D-dimer from the breakdown of the real clot, not from the breakdown of fibrinogen. Therefore, normal plasma does not have detectable amounts of fibrin of the D-dimer. Remember that clots are always forming, always being broken down at the same time, so even small normal clots give off enough FDPs to make the FDP test register as positive. Picture in your textbook on page 790 that shows the formation of the fibrin degradation products, but it just doesn't include the D-dimer products, but it just shows you a little visual of what is going down in the process of breaking down a blood clot. Radiologic tests include the arteriogram and venogram to identify blood clots in the system. These are non-invasive X-ray studies that involve injecting a radio-opaque contrast material or dye into an artery or vein to show the integrity of blood flow through the vessels. The ultrasound is a non-invasive venous study to assess for clots. Primary prevention of hemophilia is genetic counseling, especially couples with a history of bleeding disorders and want to start a family. They need to understand the medical facts, risks, and options and make an informed decision. Primary prevention of thrombosis is to prevent blood stasis and prevent increased blood viscosity or vessel injury. Health promotion of smoking cessation, adequate hydration, exercise and walking will also help to prevent the formation of a thrombi.